Buenos días. Es un honor para mí moderar esta mesa de inmunoterapia en primera línea de pacientes con cáncer de pulmón microcítico estadio 4, juntamente con la doctora Pilar Garrido. Queremos agradecer a la Fundación ECO por su invitación, al doctor Vicente Guillem, al doctor Mariano Provencio, y felicitarles por la iniciativa. Y bueno, es una mesa que realmente va a tener mucho debate porque es una...
Going to have a lot of discussion because we have different possibilities right now in lung cancer, and we have 4 speakers who are experts in this topic. So without further ado, I'll introduce the first speaker, Dr. Maya Godfrey, Director of the Institute of Meir Medical Center in Israel. She's a professor at a medical school in Tel Aviv University. She's a world expert in tailored oncology, medicine, and therapies, and she's a friend.
Gracias, muchas gracias, Enriqueta, for the presentation. I didn't understand so much, but it's okay. Buenos dias, everybody. So I will ask to start monotherapy in first-line setting in non-small cell lung cancer. I will put the presentation, but I cannot move anything. I cannot move the slides because you put on the presentation. If you want, I have to share my presentation in order to move the slides. I cannot move the slides.
No sé si el equipo técnico puede ayudar a la doctora Gottfried, que no puede mover las diapositivas.
Perhaps the technical staff can help.
So I cannot move the slides. No, it doesn't respond.
Espero un momento.
Sorry for that, Maya.
If you let me, I would do share presentation and I move the, if you want, I will move it by myself.
Yes, wait a moment, please.
So I won't do anything, okay? Okay, those are my disclosures. So the elderly physician among us remember the plateau results of the platinum-based chemotherapy with the new generation, and the survival curve was very sad. What has been changed in the last decade, especially, is first of all understanding the importance of differentiation between squamous and non-squamous cell carcinoma, the development of target treatment, and of course, for 80% of our patients, the checkpoint inhibitors. So binding the PD-1 to the PD-L1 downregulated T-cell effector. In order to restore the T-cell function, we have to have antibody against PD-1 or PD-L1. And the PD-L1 is well-known biomarker, prognostic biomarker with 3 levels: negative, below 1%, weakly positive, or highly positive, above 50%. Do we have another predictive biomarkers? So this is retrospective analysis about CDK11 and KAP1 that shows when the patients have mutated CDK11 or KAP and low TMB, there's shorter in PFS and short overall survival. So the immunotherapy checkpoint have been approved in second-line setting, and we don't have any data to distinguish between the PD-1 blockers and the PD-L1 in the second-line setting. What I like to share with you is the 5 years long-term survival of the phase 1 Keynote 001. It was a very large phase 1 study, included almost 500 patients having pembro 2 milligrams per kilo, 10 milligrams per kilo, or 10 milligrams every 2 weeks. Patients were included 20% naive patient and 20% heavily pretreated. 5 year survival of patients who have PD-L1 more than 50 who were naive means that the pembro was first-line setting. After 5 years, we have reached almost a third of them alive. And this is the survival curve, unbelievable about what we knew comparing to the past. And for patients who were previously treated, 25% are alive after 5 years. Long term also was seen with nivolumab Opdivo in a second-line setting comparing to docetaxel. And then you can see that after 5 years, 30% of the patients are alive. So the changing paradigm in the first-line setting was the keynote 024. That was included patient in a good performance status, CGFR and ALK negative, randomization, patient with PD-L1 strongly positive, about 50%, between the doublet that we know, comparing to monotherapy, pembro, at a fixed dose of 200 milligrams. Patients who were allocated to the platinum doublet in terms of progressive disease could have crossover to pembro in a second-line setting. Primary endpoint was PFS, and overall survival was secondary endpoint, response rate, and safety. So 305 patients were randomized to platinum-based. The platinum was the choice of the investigators, cis or carboplatin. And we have an update of 5 years of this trial. So 155 are allocated to pembro monotherapy, 151 allocated to platinum-based chemotherapy. The median time of randomization to the cutoff was 16 months. If we looked at the baseline characteristics, we see that they are well balanced. Median age was 65, good performance status. 90% was from Asian population. Most of the patients were current former smokers, and around 10 to 80% have had brain metastases treated before. Now the update for 39 patients who completed 2 years of pembro. As you can see, these are the patient characteristics. And a special subgroups who have completed 2 years of pembro and second course of pembro rechallenge when they did have progressive disease. So this is the overall survival. As you can see, the separation of the curve start in the beginning comparing to chemotherapy, and after 5 years, statistically different in favor of pembro, comparing to the standard was their platinum-based chemotherapy, 31%, double than the number in the chemotherapy arm, with median months of 26 comparing to 30 months. And this is really exciting after 5 years to see those results in metastatic setting, in metastatic patients achieved with monotherapy and with some of the patient complete response. The primary endpoint was reached, as you can see, hazard ratio is great, or 15 in terms of PFS, and in terms of objective response, we can see in the pembro arm almost double than the chemotherapy arm. And what is very interesting is the duration of response, 29 months in the pembro arm comparing to 6 months only in the chemotherapy arm. And this is really exciting and in terms of results of monotherapy. If we looked at patients who have completed 35 cycle mean, they ending 2 years of pembro, in the day of cutoff, half of them were alive without progressive disease and without further treatment. And we have 12 patients who were alive at the day of cutoff, who were restarted a pembro rechallenge around 6 to 12 months after stopping the 2 years of treatment. 42% of them are alive without PD and the date of the assessment that was presented this year in the ASCO meeting. In terms of adverse event, after 2 years, we didn't have a new safety signal, and we didn't have new grade 3 or 5 or allergic to death changing after 2 years of treatment, as you can see after 2 years of treatment. If we do a pool analysis from patients with brain metastasis treating by monotherapy TPS more than 50% with brain metastasis, the survival curve of them is similar to patients without brain metastasis. So just to remind you, to this study, patient could be included with brain metastasis after showing stabilization of response in treatment of brain metastasis. Most of them received a stereotactic radiotherapy. So in conclusion, after 5 years, Pembro continued to show magnificent improvement in overall survival and especially a durable response versus chemotherapy. And despite the crossover of the patient, still the overall survival is double in the Pembro arm comparing to the chemotherapy arm. In terms of toxicity, no signal, better tolerance of the monotherapy comparing to doublet, and this is the standard of care for patients in metastatic setting with TPS above 50%. We have to face that we have reached a new immune-related toxicity that are unique for immune treatment. It can be affected each organ it is. The majority of the patient will experience toxicity grade 1 or 2, but we have to remember that some of the toxicity may be very severe or fatal, and we have to know them, to be alert, to recognize it very early, and to treat them. And the treatment is according to the grading from 1 to 4. Grade 3 and 4, we have to stop the treatment. We have to give high-dose corticosteroid, and what we have to remember is to taper down very slowly. Beside endocrinopathy and dermatological toxicity, we will hold the immunotherapy forever. The majority of the patient will experience toxicity in the first 8 to 12 weeks, but we have to remember that some of the toxicity, like pneumonitis, endocrinopathy, and hepatitis, may occur very late, so we have to check the patient each time. What about immunotherapy for patients who have alteration, gene alteration, EGFR, ALK, and RET? Even if they have PD-L1 expression, they do not respond to immunotherapy as monotherapy, and we have to remember, in contrary, KRAS and BRAF, which we find most in the smoker patient, will respond to immunotherapy. What was published last year is very interesting in the United States. In the United States, only minority of the patients, 45% of them, will receive biomarker-driven treatment. And the patient, if he have mutation, 55 of them will not have target therapy, but will be treated with immunotherapy. So this evidence suggests that the oncologists are testing so little and ignore often the information that may be very important for the patient. What do I mean by that? If we take 126 patients with EGFR who have been treated with PD-L1 blockers instead of Tagrisso, a quarter of them, 24 of them, will develop severe immune-related toxicity, including pneumonitis, and no response. In contrary, no severe immune-related toxicity were identified when Tagrisso was given before the immunotherapy, as it should be. So immunotherapy should be given correctly, not upfront, for patients who harbor EGFR mutant. And now I will not talk about the combination, but several studies have been showing that chemo, IO chemo, and sometimes IO treatment are effective treatment for our patient. So hope to see you soon when we will talk about cure in metastatic setting. Thank you very much for your attention, and I wish you a fruitful meeting and have a great weekend. Thank you.
Thank you so much, Maya, for your excellent presentation. I know you are not going to be able to be with us at the time of the discussion, so we have time for at least one burning question. I don't know if my colleagues have some question. If not, I would say, are you really positive about curation of advanced stages? When you think this could be a real option for some patients? What is your feeling?
My feeling is that I have two patients. One received Pembro, and we stopped Pembro in September 2050 due to toxicity. She was received the Pembro in a second-line setting after failure of first-line setting, and you know, patient who failed platinum-based chemotherapy, he lives few months and several months only. And now, after 5 years, she has PET negative, and she is a good performance status and no evidence of disease. And I have other two patients with monotherapy in a first-line setting from the 24 trials that showing almost 5 years without evidence of disease. So as you see, I'm an old lady and more than 13 years dealing with lung cancer. And if you ask Enriqueta, not you, Pilar, you are very young, have you ever saw patients who live without evidence of disease for so many years? She will tell you no before. Because what we achieve with the target treatment is prolongation of life. But patients are not cured. They are living with the disease, and we prolong life even for several years, yes, but then they die after 7, 8, 10. Here I'm talking about no evidence of disease for 5 years. So maybe in the near future, we will talk about cure.
Yeah, I would be very happy to discuss about that. No, it's really an extraordinary time for our patients, at least for some of them. So thank you so much again for your contribution to this session, and hope to see you again soon not virtually. I would like.
Thank you for inviting me. Bye-bye. Thank you.
Thank you, Maya.
Bye-bye, Maya.
Bye.
Everybody, bye.
Bueno, ahora es mi oportunidad para presentar a Delvis Rodríguez, bien conocido.
I would like to introduce Delvis Rodriguez, who is a doctor well known by all of us. He has a very strong track record in immunotherapy and lung cancer. He works at the University Hospital of the Canary Islands, and he's going to talk to us about the different combinations of IO in first-line treatment. Thank you very much for being with us, Delvis. You have the floor. Thank you very much, Pilar, for this kind invitation today. We have seen the first monotherapy talk, and I have the combination talk. We have seen a very fruitful period. These are my conflicts of interest, and if we talk about combination, I would like to start by talking about the immunocircuit. We have tremendous opportunities, and we look where we can tackle the endless amounts of combinations of drugs. I'm not going to overwhelm you with all of them, but in 2006, and this is not so long ago, only 14 years ago, we only had a trial, and we have more than 3,000 trials. The possibilities to combine with radiotherapy, chemotherapy, antigenic. And I'm going to focus on the chemotherapy combinations, talking about stage 3 studies, immunocheckpoints, and also antigenics in immunotherapy. I do have my limitations when talking about the combinations because the talk said it was immunotherapy with the immunocheckpoint for the unnegative population. So the question is, when we treat our patients, do we really know if they are negative or not? Well, not always. This is not so frequent. PD-L1 is a biomarker, but we know it isn't perfect. There is a group of patients that are PD-L1 negative that are long survivors. Do we know anything about the mutational charge? And there's data we'd like to discuss when we are amidst panels, which is the genetic signature immunoresistance ID from that gives us the answer to immunotherapy. We know that tumors are heterogeneous and that the immunity is dynamic. It's not the same treating a patient in a moment really after adjuvancy and then treating a metastatic patient. Some are inflamed, some are immunodesert, and some are immune-excluded tumors. This is not coffee for all. Immunotherapy is not valid for anyone. And lung cancer is the biggest example in the customization, the subdivision of different kinds of groups. We need to carry out personalized immunotherapy, and I would like this feature to be like this. The scammers, non-scammers, and immune studies. These are phase 3 studies. Most of them are phase 3, but these are only phase 2. We've got 7 trials presented so far. The first one is the Keynote 189 plus Pembro and Platinum Pemet. This has been approved by the FDA. The other one is the American study, Carbo plus acetaminumab, 132, Ateza plus Carbo, Pembro, and Ateza versus carbonated shell. And recently, in August, we had the Orient 11 study, which is a study with the sintilimab. There's been other drugs included this year. Sintilimab, this is a study presented comparing platinum versus Vermetexel platinum. Positive study for both, presenting interesting OS. It was presented recently. We also had rationale 304 with tislelizumab plus platinum with no mature data, and the final Asian study, which is presented in EMRO. It is a Tesuki 52 Niva plus Beva Carbo plus. PFS positive and the OS is missing. I would like to share 3 slides on the northern squamous, where we have seen that the PD-L1 positive population with an HR of 0.73 with a median survival is 22 months versus 16 months versus Avastin, which is the standard study that clearly showed different OS. However, in the recent update, if you take a look at the negative PD-L1, from a number point of view, it doesn't reach this. And then I would like to focus on carboxyloxin against tocilizumab. I allowed including these patients. In the Martin Wright poster, we've seen that the mutated NFR population, which is 10% of the study, we have seen ratios of 0.60 in patients with these mutations. And this is very important because we hadn't have any information. And we have very good data on afatinib, but in those patients that are not 90M or that progress, we have to apply chemotherapy, and we'll have to prove this. This would have been the best scheme for the NFR disease with progression. The final analysis presented on Keynote 189 that we will soon present for 4 years. In 2 years, 45% of the patients were alive in the combo of Platino Pembro versus 27% of the patients. And please note, with a crossover of 54% at PFS, which was clearly benefiting the branch Pembro-Embro. I'm going to introduce here, and this is very important because people still ask, is this only for PD-L1 positive? No, all of them benefit. If you take a look at this ratio is even better. If you take a look at the liver metastases, you had seen with the Keynote 189, Gracino's data. Remember that 16% of the patients in Keynote 189 had metastases liver, and of these we clearly see that there is a 40% of death reduction, those starting with Pembro, and 80% of the patients in this study had a brain metastasis, and many of them hadn't even received radiotherapy, and they had also benefited from the data. In terms of Orient 11, resintrimab, we have seen the positive PSF 0.48, two ratios around 0.60. We are going to have groups benefiting all PFS in PD-L1 negative with very short segments. As far as squamous, we have full trials of phase 3 with pembrolizumab, carbo-paclitaxel versus carboplatin or versus carbo-paclitaxel combined with pembrolizumab, and the Empower, which is positive for PSF and overall survival with the EMA and FDA approval. Empower 131, which was combining carbotaxol or carbonatixel plus atezolizumab versus carbonatixel. So the Empower 131 was positive for PSF, but not for overall survival. Oriental, which was presented this year in ESMO, same sintilimab plus platinum gemzar, and it is an interesting study. However, in Europe, the most commonly used scheme has a very important rationale because this reduces the regulating cells. It is positive for PFS, but not mature for OS. Teslizumab, which was presented in ASCO this year, it wasn't an oral presentation for non-squamous. It was a posterization study. Teslizumab versus carbotaxol versus carbotaxol. Positive study for PPSF without any overall survival data. This is the updated 407 Keynote. Despite the crossover of 50%, the overall survival is 0.71, a median of 17 against 11 months against the PFS. The Orient 12 study, positive PFS, the median overall survival hasn't been reached. and it's been a very short follow-up. And the partner, carbo is a very good companion. Most of them benefit, but it seems that the biggest beneficiary is PDL negative, because when we talk about the combo immune, despite the histology, this Dorva versus trelimumab negative for PFS and for overall survival. The second study, the Checkmate 227, with one for PDL negative and another one for positive for PFS and OS. And the latest one, which is a very interesting study, the Checkmate 9LA, responding to the question, do we need to apply 4 cycles of chemotherapy, or perhaps with 2 is enough? 2 cycles of chemotherapy and the maintenance with the and it is positive in OS and PFS. We don't know the information, but we do not have the information yet. I'm going to apply the information. Negative MYSTIC for OS and PFS, depending on the mutational load, it seems the overall survival can be improved. In a sub-analysis, this is not valuable to me. The 227 is positive for PFS, comparing NIVA, positive for PDL1 above 1%. But we have updated the 3-year survival data, and I am pleased to see that there is 1/3 alive patients in PDL1 positive, but also in PDL1 negative, although this wasn't the primary endpoint, which is very relevant because it's precisely where we wanted data on PDL negative. Take a look at the beginning of the curve. Having 1/3 of the patients with only immunotherapy alive 3 years down the road is very positive. The final study, the Checkmate 9LA, with a compared study to chemotherapy cycles every 2 weeks, and in both cases, the primary endpoint was the overall survival. For the non-squamous and squamous, positive overall survival data, 0.69 on non-squamous, and a ratio in squamous positive or 0.60. If we take a look at the PDL1, they all benefit. Negative PDL1 and positive PDL1 and strongly positive. Only this stage 2 study to talk about the tiragolumab and atezolizumab. Please remember that the strongly positive PDL1 positive clearly shows a very strong potential for this combination. Based on the combo therapy data and based on the long survival data from Maya Gottfried, can we eliminate chemotherapy to very strongly positive PDL1? Take a look at the 0.24, 181 and 150, all the studies on monotherapy and in combination therapy. After a year, we have lost 1/3 of the patients. So same happens with the 9LA and then 227. So it doesn't matter whether it's with monotherapy and chemotherapy. What's real is that it seems that with chemotherapy, we managed to rescue a group of patients. The curve crosses with the immunotherapy and not with a combination. And if we now take a look at the chart, it is very similar. The PFS is very similar. But the toxicity with combo adds greater toxicity. To conclude, this is the algorithm, which is the very recent standard, and it coincides with the ESMO. I would divide very strongly positive PD-L1 less than 50%. I don't see any place for monotherapy for very strongly positive. Pembro, we also have the Atezo Empower 110 recently presented in the Empower study. And for all of them, PD-L1 positive and negative, KIRAD 189, the data from the Empower. We also have obviously data from the Checkmate 227. If it's squamous, we do not do anything, but we divide it in PD-L1 negative and 2. And if it's over 50%, we've got Pembro, Atezo, and we also have data of Atezo plus chemo and but this is a sub-analysis with no approval. Data from 407 for positive and negative, 227. And ladies and gentlemen, we've got Checkmate 9LA, a new standard of care for squamous and non-squamous that's combining the others. I don't know where we're going to put sintilimab with the orange studies. So to conclude, please remember that chemotherapy plus IO is a new standard of care in 1L NSCLC in all levels of PD-L1 minus. And I would like to know what is the IO with long-term survival. Which ones need CT, BEVA, ATE for better ORR and EGFR? What about the study against study trial, but we have no face-to-face stage 3 trials, especially when we need a greater markets. Thank you very much, Luis, for the excellent presentation. We will have a discussion at the end. You know the next speaker, Bartomeu Masuti, head of the Medical Oncology Department of the University Hospital of Alicante and several public bodies and a great expert. It is a luxury to have you here, Bartomeu, to talk about the optimal approach for patients. Thank you very much indeed.
Good morning, thank you all, and I would like to thank ECO Foundation. Yes, in these complicated times, they're doing a great effort, but I'm not seeing my my slides. Could you please share them?
Perfecto. Bien, como decía, muchas gracias a Fundación.
Great, perfect. I would like to thank ECO Foundation. I would like to thank the moderators. And what I'm going to do is that after this wonderful presentations, I'm going to give you an approach to the clinical reality. So what factors allow us to decide? I cannot change slides. Okay. There's a difference between decide and allow, because I'm considering the possibilities of repayment and authorization. If you allow me, I'm going to say something different at the beginning. There were two main factors of the past years that have changed the situation of NSCLC for the past years: genomic therapies and immunotherapy. They've been the game changers. This comes from chess, and they allow us to take a leap to a different level. I would like to remind you of two things. The impact of targeted therapies is measured in PFS, disease control, and what a therapy offers on a global level is an increase of survival. To long survival, it opens the issue of identifying these patients beforehand. This is a SWOT analysis of targeted therapies and immunotherapy. Both have the threat of cost and sustainability, but then, as Delvis has explained, we need accuracy. This is a treatment which is efficient for many tumors, but we need the prediction capabilities that targeted therapies have. I would like to remind you of these things. These are available therapies with immunotherapy, patients without genomic alterations, immunotherapy with plus monotherapy, immunotherapy plus immunotherapy, or chemotherapy. If we study PFS, the medians are going to be below 9 months. The ones that are less than a year, more than half of our patients, even before 9 months, they have progressed. And therefore, some of them can be rescued and taken too long, survival through second-line therapies. But the difficulty we have is this one. And we cannot be thrilled about this. We need to be aware of this. This is what I wanted to show you. This is my last slide on targeted therapy, which are the circumstances that lead the decision on therapy. Histology, the presence of genome alterations of PD-1 level, they motivate us to take this decision. If we get into detail, patients without genomic alterations, histology, and PD-1 expression. It says EMA, but it should be the Spanish drug agency. And in bold, you have options that we can really afford, or that are funded by the system. As previous speakers have explained, these are the 3 lines. IO monotherapy, 3 studies. Keynote, actually 4. 2 with Pembro, 1 with Nivo, and 1 with Atezo. They were previously mentioned. Then we move on to chemo and immunotherapy. Studies have been presented by Delvis. We'll go through them in a very summarized way. And then the 3rd level would be double immuno plus chemotherapy. This is the distribution of the trials, which are the ones that took us to the approval of the indications. And secondly, they are our reference in our clinical practice. Histology and PD-1. Studies were designed with these 2 parameters, and this is important too. They could have been designed differently. You see them here. Basically, the 3 steps: immunotherapy, monotherapy, immuno plus chemo, and the crossing with histology and PD-1 levels established by immunohistochemistry. In red, you see PFS positive. They comply with this parameter, and the ones in net in black, they have not shown improvements compared to the control arm. Let's see one by one. The first one was Keynote 024. In the literature reference, well, some charts have been updated in different conferences. So this is the option of chemo versus immunotherapy in first-line patients with tumor over 50% of PD-1 expression, 305 randomized patients, and crossover possibility in case of progression, maintaining Pembro until progression, a maximum of 2 years. The lines, well, you're familiar with them. The hazard ratio for PFS is 0.50 and for survival is 0.62. Virtually twice the number of survivals after 5 years. This is a game changer, as we were saying, in metastatic lung cancer. There's an increase, but not that significant. And this is repeated in all the immunotherapy strategies. What we see is an extension of the response rate median. The second study is more complex. Patients are not selected based on PD-1 expression, just because they were positive, more than 1% of expression, and the primary endpoint was survival in the different stages. And if we take a look at PFS, in this population, which is less selected until 8 months, up to 8 months, there's more progression in patients receiving pembro instead of chemo. And if we take a look at survival, the hazard ratio is 0.8 to 1, but up to 9 months, survival is worse for those receiving immunotherapy upfront. But the benefit is higher. This initial lack of benefit is lower in patients in the cohort of plus more than 50%. We see an increase of response that is not seen in general cohort. As I've said before, chemotherapy has more adverse events than the others. The next study is Empower 110. Here we measure the expression in tumor cells and microenvironment cells. The primary endpoint is OS in the general population, and here this goal, well, the hazard ratio is just 0.83, and in the cohort of high expression, the hazard ratio of survival is 0.59. This study has not been published yet. High expressors, as Deleuze was saying, are the subgroup that could be for immunotherapy and monotherapy. Then we have combinations. Let's start with pembro plus chemotherapy in squamous histology. What we're seeing here, and I think this is important, if we don't select based on PD-1, PD-1 expression is highly correlated with the response or non-progression, in this case analyzing PFS. And if we look at patients with survival, patients that haven't died or not progressed, or also pure progression, we have hazard ratios close to 0.60, which I think validated this strategy in squamous, although as of today it's not funded in our system. What we're seeing is an increase of response clearer than when it was just immunotherapy, and we also see this in the extension of survival. I think that in squamous histology, the impact of any of this is similar to non-squamous, but the survival is below to adenocarcinomas. Let's continue with non-squamous. The study that has a higher impact in clinical practice was Keynote 189, pembro, carbo, or cis plus pemetrexed with the maintenance of both versus carbo, cis, pemetrexed, and placebo with maintenance of pemetrexed and the possibility of crossover. We see the same thing. The expression of PD-1 is correlated to non-progression. The higher the PD-1 progression, the lower the risk of progression is. Here we also see that the impact in survival in the different cohorts is higher when we have a PD-1 of high expression of PD-1. Globally, the study is positive. That's why it had an impact in the practice, and doubles the survival median. And it doesn't double, but survival after 2 years, it's higher, with a SR ratio of 0.56. The other combination study has been previously mentioned, Atezo, chemo, and Bevo in power 150. We have the same thing. Delvis has mentioned it. I apologize. I don't know what's happening. So the same thing, we have an increase of responses. Combination therapies increase secondary effects, which is side effects, which is reasonable, and the effect is proportional in PFS with the expression of PD-1. Same histology, a study which is difficult to apply in our milieu, and the design was questionable. We should review the studies that led to this, because they condition the clinical practice. It's a significant study, but has no impact in our study, because chiropractic cell is not funded in our system, but it's a peculiar study with carbo, naplactic cell plus supportive care or said, but there are no clinical trials that actually support this. In this study with Atezo plus chemotherapy without anti-angiogenic, because squamous histology, there's an impact in survival, but it is not statistically significant. And finally, immunomonotherapy, immuno versus immunotherapy. Take me to 127. We would need to have a specific session to study the design, but as Delvis has explained, what this study is showing is that there were two parallel cohorts with different endpoints based on TMB and PD-1 expression. But the message, as he explained, is that probably in patients that responded, and this is important because you see this afterwards, the benefit of double immunotherapy is maintained through time. It's similar for PD-1 positive and negative, and it's higher than immunomonotherapy, especially in PD-1 negative population. And the last study mentioned by Delvis, which, although it hasn't funded yet, but I think they're going to have a clear impact in our clinical practice. It's a combination of two chemo courses plus double immuno versus chemotherapy for cycles. There are questionable issues in the design because these patients continue in the experiment arm with therapy with immunotherapy. There's the control arm. You have the option of pemetrexed in non-squamous histology, but the design is questionable. For this decision, we need data related to efficiency, efficacy, and safety, but we need to bear in mind the patient characteristics, comorbidities, performance, disease characteristics, and tumor characteristics. And I wanted to add something here. We have biomarkers that come from tumor cell, from critical factors, and the immune system. But the most analyzed ones, well, there's an intersection between the host, the tumor, and the microenvironment. And the complexity of the approach with immunotherapy comes from this. Probably the clearest idea is that the intersection of PD-1 expression, mutational load, and effector T cell density. But there's a regulator environment. What I wanted to say regarding PD-1, well, it's been approved as a marker, but we need to think, because there are spatial and temporary variations. These are dynamic situations, Delvis explained. Therefore, it's an imperfect, clearly imperfect biomarker. And it's a continuous variable. If it's binary, either below 50 or over 50, we're simplifying here. This is a communication of ASCO this year. Patients with PD-L1 over 90 versus 50 to 89. In other words, everyone included in high expression cohort, we see a hazard ratio in first line of 0.78 in survival, with the difference of approximately 8 months, 7 months in the survival median for those who have a very high expression of PD-L1. So there's clear room for improvement. You just have a couple of minutes, 2 minutes. So the intersection with the characteristics of the patients, this is what I'm showing here. The performance status is critical to obtain a response, the progression-free survival, and at the end, although the hazard ratio is 0.42, patients with lower performance status, they have associated comorbidities. PD-L1 versus TMB. This is an open discussion, but probably for the things I mentioned in the beginning, which is the prediction of lung survival, TMB appears to be more predictive. Interaction with dynamic genomic expression profiles of inflammatory T cells. This is important, and correlation is also important. Mutation in STK11 and KEAP are non-significant for the impact of immunotherapy, but the changes in NAD1 increase the probability of response. These are the final messages. We have changed the options and the outcomes of treating NSCLC. I think long-term survival is the main value of immunotherapy, but the immune response is very complex. And although we're taking decisions based on drugs being approved, obviously based on histology and PD-L1 IHC, I would like to say that we're losing lots of patients at the beginning. Histology is a known factor, and that as of today defines combination therapy rather than immunotherapy, and that PD-L1 is predictive mainly for response and PFS. And what we need is developing multi-parameter decision criteria on the way. Thank you very much. My last sentence was that this needs to be interpreted in statistic terms. This is an Italian physician that lives in Paris. He says that in an uncertain world, which is obvious, the lack of knowledge does not mean that we don't know anything. In this scenario, statistics is a useful tool to guide us when we do not have complete knowledge. But I would say that we don't have tools to compare studies, and that would be the data that we have every day. Thank you very much. Thank you very much. Thank you very much for keeping to your allocated time.
Also in lung cancer and thoracic tumor from a hospital in Oporto. His talk today is about predictive diagnosis in lung cancer with immunotherapy. Thank you so much for being with us.
Thank you. Good morning to all. First of all, let me thank to ECHO Foundation and particularly to my dear friends Carlos Camps and Vicente Guilherme and Mariano Provencio, the invitation to participate in this event. And salute the chairs of this session, my friends Enrique de Filipe and Pilar. Thank you for being here. In the next few minutes, I'm going to talk about the value of predictive diagnosis in decision making for immunotherapy in first line non-small cell lung cancer, stage 4. Let me. Okay, these are my disclosures. Well, as we already saw, Immunotherapy with or without chemotherapy brought statistical significant longer overall survival when compared with chemotherapy alone and with the better quality of life. And this is for that reason that when we do not have any drive mutation nowadays, immunotherapy or immunotherapy plus chemotherapy are the treatments of choice for stage 4 non-small cell lung cancer, as Elvis and Bartomeu has already stated. And when we go back to the bench, we know that we have several mechanisms that could be potential predictive of response to immunotherapy. Some related to tumor cells like PD-L1 expression, tumor mutational burden, or DDR pathways. Others connected to microenvironment, like tumor infiltrating lunar cells. Others correlated to circulating factors. The most studied is circulating tumor DNA. Others associated to host-related factors like age, gender, or intestinal microbiota. And finally, others linked to immune-related adverse events. From all these possible predictive markers, only PD-L1 expression and MMR deficiency are clinically approved. Most of the others are in clinical trials or in ongoing research. Nevertheless, for lung cancer, the most studied are PD-L1 expression and tumor mutation burden. As Bartomeu already stated, also regarding PD-L1, this is not a good biomarker for several reasons. The first one, it's not a binary biomarker. It varies in expression during the biological continuum of cancer evolution, and so its predictive potential is weak. But it varies also in terms of the spatial evaluation of the tumor and with the antibodies used for the immune cells proportion scores. Nevertheless, we know that more than 45% of the tumors do not express PD-L1, and the response to immune checkpoint inhibitors increase with the increase of its expression, but we have a considerable overlap in response. And so, in summary, the proportion of patients who derive limited or no benefit from PD-1 or PD-L1 inhibition is about 70 to 80%. Only about 20 to 30% of our patients have an objective response to PD-1 or PD-L1 inhibition with a likely substantial overall survival benefit. That is why we need other predictive biomarkers. And the other potential predictive biomarker for immunotherapy is tumor mutational burden. The high immunogenicity of tumors with high mutation burden makes them a rational target for treatment. And lung cancer has one of the highest percentage of mutations, as you see here, just behind melanoma and other skin cancers. Therefore, tumor mutational burden has been incorporated in several clinical trials from 2015, particularly in first-line treatment of non-small cell lung cancer. But although we know that tumor mutational burden could be a prognostic factor for non-small cell lung cancer, we know also that it correlates with response to immunotherapy treatment in non-small cell lung cancer. And so, the last phase 3 clinical trial implementing an evaluation of progression-free survival with tumor mutational burden was CheckMate 227 for a population of stage 4 non-small cell lung cancer in first line of treatment randomized by PD-L1 expression. One of the primary endpoints was progression-free survival in tumor mutational burden selected population treated with nivo plus ipi versus chemo. And the results show that when we have high tumor mutational burden, the combination of EP plus nivo is superior to chemotherapy independently of tumor of PD-L1 expression. Moreover, if we have low tumor mutational burden and low expression of PD-L1, the IO combo was not different in terms of efficacy from chemotherapy. Nevertheless, to consider tumor mutational burden as a predictive biomarker for immunotherapy treatment in non-small cell lung cancer, we still have some problems to solve. We know that a higher proportion of mutations does not always result in neoantigens, and tumor mutations can increase the possibility of cancers being immunogenic. But tumor mutational burden does not represent direct evidence of immunogenicity and does not accurately predict immune response. The predictive value of tumor mutational burden in terms of the efficacy may not outweigh the value of PD-L1 expression, but the combination of both biomarkers may be a useful clinical tool. In terms of challenges regarding tumor mutational burden, we have the turnaround time, the cost, the complexity of data interpretation, and we do not have any established cutoffs. But the combination of both the expression of PD-L1 and tumor mutational burden could be more accurately in terms of prediction of response to immunotherapy than each one isolated. This meta-analysis of IO versus chemo published last year shows the curves of PFS and overall survival regarding high or low PD-L1 expression or tumor mutational burden. And if you see, they are remarkably similar to others observed in phase 3 clinical trials. But when we compare the degree of prediction of each isolated biomarker with the combination of these two, we observe that it is much more accurate combination for prediction of progression-free survival. Other studies are developing other combinations of various factors to better predict response to immunotherapy. One of the studies is about the combination of tumor mutational load, expression of PD-L1, CD8 T cells, and the expression of HLA class 1. And this combination of biomarkers seems to have some potential to predict response to immunotherapy. Other studies are looking at the potential of the lung immune prognostic index. That is an index that uses derived neutrophil to lymphocyte ratio plus the level of LDH. And it seems also to have some potential for predict immunotherapy response. Others are looking at the tumor infiltrating immune related long non-coding RNA signatures, and it seems that it could have some potential also for predict response. But others are using a machine learning by gene expression context and PD-L1, creating predictive models with a potential application to our clinical daily practice. But it's my firm belief that we will evolve to use liquid biopsy to determine some biomarkers like cell-free DNA, circulating tumor cells, or exosomes that combined with PD-L1 expression and tumor mutational burden could guide us in the choice of the best treatment for our patients in terms of immunotherapy, or the combination of NGS evaluation combined with other omics and network structure data with the help of mathematical models that will help us to decide how best treat our patients to reach significant increments in survival for our patients to reach a level compared to some of liquid tumors. And with that, I thanks your attention.
Muchísimas gracias por la presentación y también otra vez por ajustarse al tiempo. Tenemos
Thank
tiempo.
you very much for your presentation. I think we have a question from the audience. I would like you to answer, all of you. In Spain, immunotherapy is for PD-L1 expression less than 50%. Who wants to start answering? I think it's the million-dollar question. We all have the same doubt. I think we need data. If we just take PD-L1, we're doing a bad job. We know it works, but it's not perfect.
But we have information missing because I see patients with high tumoral burden, and what I want to do is to apply chemoimmunotherapy, not monotherapy. But perhaps the patient had 100% of PD-L1 high mutational burden, perhaps, and they're going to respond well. But this is information I'm not having. However, I have one with 80% and the other biomarkers of resistance, and such patient is the one that really receives immune. That's why I keep on insisting. We have gone a long way, but we have 7 studies, stage 3, 4 on non-squamous, 6 more on monoimmune. Don't you think we're always doing all the same? So perhaps looking for other more important biomarkers, perhaps we need to do that. But obviously, we need to apply this to other patients. And
es el nudo gordiano de la cuestión, quiero decir, y es lo que causa más inquietud.
This is the greatest source of insatisfaction, because in a scenario in Spain and with public financing, this is the dilemma. Patients with more than 50% expression of PD-L1 only, we want to treat them with immunotherapy with a single agent. So this is obviously a too broad spectrum. The regulatory authorities have proven short-sightedness or incapacity to grasp the complexity of the scenario. But it's also true, as I already mentioned, the design of studies, which are all these trials that are very conservative, probably have some responsibility under that scenario where we are. So this is the reality, and I think it's quite worrying. So not only because of PD-L1, it doesn't matter for regulatory purposes. We've got 50, and it doesn't matter. Okay, we apply 65. The problem persists, and I cannot solve it.
Em Portugal es lo mismo. Quando nós empezávamos quimioterapia num paciente, nós não sabíamos que paciente iria responder e não. E com a quimioimuno é lo mismo. Quando empezamos quimioimuno ou solo imuno, nós não sabemos que paciente vai responder. Efetivamente, os ensaios nos conduziram a marca de 50%, mas nós sabemos que PD-L1 não é marcador ideal e que a relação entre o tumor e o sistema imunológico do paciente vai variando durante o contínuo da evolução do câncer. É uma marca solo
puede continuar.
Así que es 50% es una marca posta por los ensayos clínicos y no quiere decir nada. Y nos falta un biomarcador que nos possa discriminar los pacientes que van a responder a quimioinmuno, solo inmuno, y que no responderán.
Antonio, en la
Que hay
situación... Piucha, por favor, sí.
Sí, perdón.
Gracias. No, que iba a comentar que creo que aparte de la pregunta de la discriminación por PDL1.
Apart from this question, the discrimination based on PD-L1, the duration of the treatment, and in that sense, I wanted to ask the three speakers, what is your opinion? The interpreter apologizes, Pilar's line is very choppy. We've got limited numbers of trials. What is your opinion? What do you do in this regard? What do you usually do? That's a question we keep on asking ourselves at all times. We have studies for 2 years. We also have a study with NIVA, so at least 1 year is not sufficient. But in response to your question, you don't know. We don't know yet. What are we doing now? I told Enriqueta Luis a few days ago, when I'm getting closer to 2 years, I see the remaining disease, but based on the clinic. But we do not have a study that responds to that. If you want the disease, perhaps I'm consolidating it. If they have a complete response, but if it's a patient with a stable disease, removing it, I find it very difficult. Nothing to add, just note that this question will have to be solved if we're capable with academic trials, and they shall attract the interest of the system managers because it has a clear economic impact. And this shall be my approach, identical as Davis. He has more experience. If there is an entire going back, you can stop. And if you have a disease, that's a dilemma. And obviously, the only data, okay, melanoma is a different disease. The entire follow-up is longer. But if the patient tolerates the treatment well, it's worrisome to leave it without treatment if you have sufficient volume of disease. Yeah, thank you. We do have a question for Antonio. Are we including new indicators, HLA, for the decision making?
Estudiando um pouco do tumor mutational burden, que não é fácil marcador de medir, requer tempo e algum estudo, algum know-how sobre ele para interpretar os dados que nos fornecem a sequenciação genética. Así que nosotros no estamos estudiando nada fácil de medir. Y pienso también que no irá a ser fácil. Estaba diciendo que como la relación entre el tumor y el sistema inmunológico do paciente es algo que va variando con el tiempo, y con los tratamientos no irá a ser fácil tener un biomarcador que seja simples e fácil de medir. Provavelmente vamos ter que ter um conjunto de biomarcadores que nos digam algo e los vamos ter que medir durante o tempo de tratamento e durante o tempo de evolução do cancro. Así que no va a ser fácil.
Siguiendo un poco con el tema no de la duración.
Now, in line with this topic, perhaps during the COVID-19 crisis, in certain centers, the intervals of administration has increased, obviously. Do you expect to maintain it after the COVID-19 crisis? What do you think? Valdez. Yeah, in some patients, I maintain it, but at the beginning, the first cycles, I prefer to do it every 3 weeks. When I see the response, and then I just space the treatment. The future of trials, they will begin since the beginning with a different formulation every 6 weeks or monthly. But this is what I do in my practice. The COVID-19 has pressed us to take decisions like this one, everything virtual. Some of them are here to stay and some others not. Same with immunotherapy that has forced us to take, certain indications. But in my daily practice, I do it, but not to every single patient, okay?
Para mí, puedo hablar por mí, me siento más seguro de empezar de 2 em 2 semanas por nível e 3 em 3.
I do 2 for Nivo and 3 for Pembro. And after 3, 6 cycles, I may do it every 4 weeks. Probably after the COVID-19, if there are no other clinical trials, we'll go back to the 2-week interval. I agree with Antonio. This is a one-off situation. And yes, we have had several adverse effects, skin effects that have led to inconveniences to patients. I don't think we need to systematically change the sequence or the scheme of dosage when you are using something that comes from clinical trials. Another question, a burning question that unfortunately has no answer yet. The dosage, single dosage, or the weight-related dosage. We know there isn't any clear answer to it. We do not know what is the threshold of efficiency or minimum efficient dose, but this is something that has a lot of impact to it. Mariano, milligrams per kilo. Even at 6 weeks doses. Most new trials have fine formulations and broader in time. I like what you said, and I think this is a proposal the Spanish group shall do, but because I have the feeling, and I shouldn't say it here, that I have greater toxicity in other patients when I have larger dosage in longer intervals. In the service, we see greater skin toxicity, directive toxicity, and therefore in certain patients I had to go back to the previous formulation of shorter intervals. there is no evidence about this, but I'm pleased to see that some of my colleagues agree about it. Enriqueta, Pilar.
Yo no he tenido, la verdad, esa experiencia.
I didn't have that experience during the peak of the pandemic. Based on the recommendations, we did extended schemes, but from June onwards, we went back to the normal one. I feel a bit insecure without evidence to do it frequently, so I do not have much experience because the patients that were going so well, we discontinued the treatment in March, April after discussing it with them. So it is a thorny issue. Enriqueta, what is your feeling about this? What's your experience? Same. During the toughest time of the pandemic, we did it. But then we went back to the usual intervals. So I cannot, conclude anything. I'd like to ask the three of you a recommendation with a 2 ECOG related to the disease, but PDL above 50% and 50% PDL negative. What would be the first line treatment? Bartomeu, it's a tricky question. From the trials point of view, these patients are not included for the chemoimmune. But in the preamble, you said it very well. The performance assessment will need to just rule out, and this is a very subjective thing. Is this related to the disease or not? So below 50%, we will have to adapt the chemotherapy IO or carbotaxol, perhaps alone, with a PDL1 below 50%. And above 50%, I would take into consideration if the ECOG is declined because of the disease, the type of metastases, and what is the need to have a closer response, the volume of the disease. But these are criteria that are more subjective. They can be perfectly discussed. Thank you. For those above 50%, I would choose monotherapy, immunotherapy. For those of less than 50%, only chemotherapy plus immune and reduction as well. There isn't any specific answer. I would do monotherapy, which does not mean that we cannot do chemoimmune, because what they said, Antonio, we all do it. We decrease the dosage. Do we need to apply 100%, especially when the ECOG is a consequence of the tumor? So then perhaps you can continue with the immune alone. Less than 50, early immune. I do chemoimmune. I think this is the end of this round table, because we had to finish at 45 past 11. I believe we have half an hour break now.
No, tienes razón. Debate hasta las 12:15.
No, debate until 15 past 11. We'll continue this discussion. Next question. If we choose IO on stage 3 or earlier ones, and if there is a patient with a very high PDL, perhaps we can choose only first line of treatment IO with a very low PDL one. Does it change your decision? Durvalumab, or if they come from a recent IO study? We have no data about this. We have no data approved to it. I use chemotherapy. It really depends on the interval and if they have spent 1 year free from it. Can we apply chemo again? So this is a reality. But if less than a year has gone by, I would see it very carefully. But there isn't any evidence. It really depends on the relapse as well. I couldn't agree more. We cannot conclude it. We will start with chemotherapy if it's an early relapse, and perhaps we choose IO later on. But what we cannot do is to set up a standard, a very clear threshold. We can say a year, but in the progression decision, chemotherapy is a standard of choice. I said 1 year just to give an example. There are no limits. Yeah, I agree with you. The study analyzes the duration of chemotherapy. We're not going to have comparison studies anytime soon. We have to compare the studies among themselves. What are the patients that may benefit from adding these in a first line of treatment? The study did not have selection criteria. The benefit was for both histologies, for the different cuts of PD-L1. So in principle, you must not look for a selection. The thing is, if this is going to be approved on this study, which is less ambitious in terms of volumes than the previous ones of registry, if we're going to be able to use it, my prognosis, we always get it wrong, but if this has a reimbursement, the use will be widespread. It'd be a majority usage. But what about the design? The design has a lot of, limitations that shall not be forgotten. The duration of the treatment, the limitation, the non-maintenance, and so on. So if there is a reimbursement, chemo plus immune or chemo plus anti-PD-1. What is your opinion about this, José Antonio? That's a very interesting question. I'm going to be like Bartomeu. I would like to see longer follow-up of PDA, because as Tomeu said, 4 cycles, but the control branch, 2 cycles of chemotherapy is okay. But why? How did they choose it? Why did they choose it? Then, if we continue this for 2-3 years, we see a roaring survival that increases to 189, 150. I have no experience with this, but the experience that I have with this, it's that it's always more toxic. However, in the studies, I never see a reflection of the toxicity I see on the clinical practice. So not only with Nivo, but also with other combinations. There very odd toxicities in cephalitis are always on these combos. I would like further monitoring. The follow-up should be longer in order to reply to your question. Some people, after 4 cycles of platinum and pembro, then I just kept them on pembro only. We're missing information, really, to take these decisions, to see who's going to be the greatest responder. If I see a young individual, I choose it because I always have the feeling that I'm extrapolating the melanoma, that they are those drugs which really allow us to maintain a longer lasting response in time. But this is mere speculation, okay? We need to wait and see how this is going to be in the long run. Yeah. We start with monotherapy or immunotherapy. Then we combine IO plus chemo. And then we increase survival, then the capacity. However, when we weigh toxicity and the moment of survival, we believe it is very beneficial for the patient. Now we are trying to combine with another drug, NSCLC. We have to see the gains in survival against toxicity we discover later on. So I would like to get a look at the survival data in order to decide a little bit when we have the combination. I like to have several options in order to choose the best treatment for my patient. But always thinking about the quality of life and how many years will they live, and again, what is going to be the quality of life, and how much will the treatment cost. I think we need more time on this clinical trial in order to get another understanding of this. Related to this, what I like about the new LA is these 2 cycles that can rescue these type of patients. In the 227, they go with immunotherapy. But my question is, with the 227, new on first line of treatment, which patients would be your target in an ideal world if everything is approved? I'm the chair now, sorry. I don't know. That's my opinion. You've mentioned this before. Perhaps we need academic studies that reply to these questions that are so relevant, because all we can do is to compare different studies from a methodological point of view. It's okay. I believe what they did, based on the different curves when they only receive IO initially, and potentially dependent on who's the promoter or the sponsor of the trial, they have the drugs, they want to combine them. I couldn't agree more with what you said. If the study shows a long-term impact on survival that could be derived from lipilimumab, this may be a change, although it is only a phase 2 comparison study with a smaller number of patients. If this is confirmed, at the beginning the curves are not crossed and the impact on low survival, this would mean probably a bigger change in the clinical practice. Interestingly, 30% after a year, we lose them. Okay. It's something we are still missing. Why not? What is your view on this?
You think this is better for patients? You presented this in ASCO, Elvis, and you've said it, the combination with anti-TIGIT. In this scenario, to try to improve what we have, which are the most promising combination you see in first line for the future? We have studied with anti-TIGIT, with PARP inhibitors. What do you think that it's more appealing? I'm sorry to repeat, but the most appealing for me would be individualizing monotherapy, customizing monotherapy, because otherwise we're going to do the same thing, same combinations, 5 more years with this. The anti-TIGIT, I like the combination anti-PD-1 and anti-TIGIT. There are others in development. I liked it because of the toxicity, because it's low, it's well tolerated, and strong positive is good, apparently. But PVR, which is the ligand of the TIGIT, data have been presented where you see that there's no difference whether it's high or low. It was recently in ASCO. I was more thrilled. I was looking forward to it. I thought that with this marker, it was going to be useful. What's going to happen with antigen 3 and others? There are studies ongoing that look for a marker, its expression in tumor cells. Together, you've studied there are many. For me, the combination with angiogenic is important. It has value together with immunotherapy. There are several of these, but I insist, as Tara always says, we need to stop saying me too. We need to stop doing the same thing, and we need to carry out more targeted and customized studies with immunotherapy. I think that this area is highly complex. It's so complex that reducing to an IHSC expression of a protein that's in the tumor and the microenvironment, well, we need to think that this is not enough, clearly not enough. So if we start to use combinations, I think that any combination should not look for a biomarker, because probably it should be a combination of biomarkers, but if we really want to move forward, I think the new combinations, besides the theoretical basis of the levels of immune response we are acting upon, they should consider a better selection of patients. This is what Dennis was saying. I agree. I think that in the short term, we will need to customize therapy using several biomarkers that will allow us to select the immunotherapy and what goes with the immunotherapy in the long term. I think we need to customize immunotherapy based on the tumor characteristics. Probably using something like CAR T cells, others, individualizing immunotherapy based on tumor characteristics. It's the future. It's what will allow us to cure our patients, maybe in stage 4. Based on this, have you seen the data with this? I thought it was very interesting, the combinations, including after patients. It was very thrilling. I know it's really complicated. Not all the centers are going to be able to do this, but I think it's beautiful. I think that in the long term, this is the way. But there are many logistic related difficulties. Yes, and technical difficulties. We need to overcome many technical difficulties. But I agree with what Antonio is saying, but I'm not optimistic in the short term. I would like to ask you about clinical decision making. We have scenarios in which we don't have answers based on clinical trials. We'll say that research should have a higher weight. We've been saying this for years, but it hasn't changed. So in this sense, well, this is a very frequent situation. There are very few clinical trials in previously treated patients, but there are patients with immunotherapy or chemotherapy in first line, then the second line of chemotherapy with docetaxel, for example, and you see a progression in a patient with the good general status. Do you consider any re-challenge? Does this condition your decision to apply immunotherapy based on the response they had in first line, although based on the data available, there's not so high correlation? How do you act? There are some studies in this line, a trial in the group, which is retreatment. The main investigators, Ruiz Pazares, retreatment in patients that had a previous line of immunotherapy. It is true that design comes from the time when immunotherapy was rather second line. But the best way to have an approach to this is having information. It's not going to be a perfect clinical trial, but we need information collected in a clinical research setting to reconsider in our clinical practice how to treat these patients. The problem is that after chemo, an immune and docetaxel patients that have a good general status, things change. I think it makes sense. Your question makes sense. Many of us have that problem, not just with docetaxel. We have patients that responded for a long time, more than a year. They progress. We go back to carboplatin or carbolinta pembro. They stayed with pembro or alinta, and after a year and a half, they progressed. Why don't we go back to carbotaxol like this? I prefer to do that go back to docetaxel. And your question makes sense. But you say, okay, immune system after docetaxel, carboplatinum, etc., is going to be the same one? Probably not. Probably it has changed and we can introduce something else. It makes sense, but we don't have data, so we cannot do it. There are ongoing studies. Sometimes I have the wish to do it when I see this type of patients. If I put PD-1, put PD anti-PD-1, but I have no experience. I wasn't able to do it. They're calling. I have to really go, so I would like to apologize. Thank you. Thank you very much. Thank you. I apologize. I have to run because they're calling me. We have 5 minutes left. I would like to speak about markers. We have to advance with biomarkers. The reality is that we work with TMB in first line, and then the literature says that yes, but not PD-1, not just PD-1 more than 1%. RNA signatures, but in Power 150 includes this. There's a clear sign, but we don't include this. It is complicated because we all understand it, but PD-1 more than 50% is the only one we have. How do we do to change this? You were mentioning me too, but the only advantage of this is competition between companies that have information either from all the patients that we include in clinical trials. I don't know. I would like to know what you think. For me, you know that PD-1 is really easy marker to include in our daily practice. It's about disseminating it through all the hospitals and pathology services. The histology of lung cancer. TMB is not an easy technique. It is not accessible to anyone. It takes a while, and you need time to interpret the data. And there's no standardization of how many pairs of megabases we need to assess the TMB. So it's not an as easy technique. It's difficult to apply on our daily practice. We need to come up with a system like the lab prognostic index to have simple things such as the expression of PD-1 or LDH level, lymphocyte infiltration in the tumor, which is something relatively easy to establish. It is difficult. We should establish a table to combine different factors and decide our treatment. What you're saying is key. In a utopian world, but a possible world, technology of data analysis, including clinical data, simple data, which are available and with the right response time, the data analysis technology and AI technology, all of these things could build this, but you should theoretically do it combining databases from patients that received Pembro plus those who received Nivo, Nivo plus EP plus Atezo. I think that this is the way forward. I don't know if the world in which we live in allows us to move forward. Data analysis technology is there, and if you put lots of clinical data, the different aspects, patient-related, tumor-related, potential biomarkers, type of metastasis, etc., etc., you could probably create a multi-factor instrument that will be more productive. But I don't know if we will success. I don't know if we will succeed in this. So now this is the time to finish. I'm not mistaking this time. Has come to close our session. I would like to thank our speakers for their excellent presentation and also for this enriching discussion, also to the co-moderator, Dr. Philippe, and Foundation ECHO. And I think this is the time for a new talk, which is called Immunoinfluencer. Thank you very much. Thank you. Thank you.